Bismillahirrahmanirrahim. I am Dr. Hena Mazhar, and this is the first presentation of this series of talks about dermoscopy in which I have tried to simplify things. Keeping pace with technical advances in diagnostics and therapeutics is challenging. Dermoscopy is one such relatively novel, extremely useful, and versatile technology. My talk is particularly relevant to those novice dermoscopists who are struggling to understand the complexities of dermoscopy in clinical practice. It's really hard to learn anything unless you know what's the importance of that subject. Look at this lesion. Does this look sinister to you? Another close-up view of the same nevus. If you apply the traditional ABCD criteria of melanoma on this lesion, this looks fairly symmetric. There is no border irregularity and there is no color variation as such. But on dermoscopy examination, this was actually a melanoma. Another one, quite a banal looking, very small, tiny nevus with maybe slight irregularity of border on one side. But on dermoscopy examination, this was a melanoma. Here is another one, a very tiny nevus with slightly irregular borders. But again, on dermoscopy, this was a melanoma. Okay, can you see anything sinister on the back of this patient? There's one small scar here. A close-up view. Doesn't this look like a scar? But in dermoscopy examination, this was actually an amelanotic melanoma. Again, another patient with a small red papule which looks like an angioma or maybe a cherry angioma. But on dermoscopy examination, this was actually an amelanotic melanoma. Another scar-like lesion, yet an amelanotic melanoma on dermoscopy. So, if you will diagnose a case of skin cancer at this stage without dermoscopy, with the help of dermatoscopes, you may be able to diagnose the patient much early. So it helps in early diagnosis of skin cancers. Look at the back of this patient. This is a case of familial atypical multiple mole and melanoma syndrome. And here is a scar from previous surgery. Without a dermatoscope in hand, which one of these lesions you will excise? Probably so many. Another patient of familial atypical multiple mole and melanoma syndrome. Sorry about the poor quality of the image. You can see a scar here, another scar here, maybe another scar here. The lesions are on the back of this patient, and in such cases, you just can't rely on the history because the lesions over the back of the patient are quite difficult to monitor. So my question to you is, without a dermatoscope in hand, which one of all these lesions you will excise? Or you won't excise any of these? I would probably excise this one, or maybe this one, or maybe this one. But out of all these lesions, only this one was sinister. This was actually a melanoma. Another patient with a small hyperpigmented skin lesion over back, which looks like ugly duckling among all his other nevi and sunspots. The close-up view of this lesion. Just apply ABCD of melanoma, the clinical ABCD. This is definitely asymmetric. There is border irregularity, there is color variation, and it's quite dark in color. But on dermoscopy, this was just a seborrheic keratosis. Another large asymmetric looking skin lesion with border irregularity and color variation, but just a seborrheic keratosis on dermoscopy. Oh, look at this one. A very pigmented, asymmetric looking lesion on the right flank of this patient probably meets the whole ABCD criteria of melanoma. But this was actually a pigmented seborrheic keratosis on dermoscopy. So the patient was discharged. So dermoscopy saves unnecessary excisions. The incidence and prevalence of melanoma in the Western world or white population is quite high. According to an estimate of American Cancer Society for melanoma in US for 2023, about more than 97,000 new melanoma cases will be diagnosed in 2023, and about 8,000 people are expected to die of melanoma, which is quite high. So, approximately 100,000 new malignant melanoma cases are diagnosed per year in US. And without using dermoscope, the number needed to treat one melanoma is 30. What does that mean? That means that in order to excise or to identify one melanoma, you'll have to excise 30 benign lesions. That means in order to diagnose 100,000 melanoma cases, you'll have to excise 3 million benign lesions. But with the help of a dermatoscope, the number of excisions has been reduced by approximately 44%. According to this study, the number needed to treat one melanoma was quite high previously without a dermatoscope, but now with the help of a dermatoscope in expert hands, it's just 5 or 6. Dermoscopy plays an important role for the assessment of lesions at special locations like mucosal surfaces, face, or genital area. Patients are usually very apprehensive when it comes to biopsying these areas. Look at this lesion, for example. Dermoscopy actually saves the biopsy of this area by revealing typical features of a labial melanosis. Another example of a pigmented lesion over face. Without a dermatoscope in hand, I would probably excise this asymmetric looking pigmented patch, but this was just a solar lentigo in dermoscopy. So in a nutshell, what's the importance of learning dermoscopy? It helps in early detection of skin cancers. It acts as a screening tool, especially keeping in view the increasing number of skin cancers all over the world. It's especially important in the special locations like face, genital area, mucosal surfaces, or nails, where this can eliminate the need for doing unnecessary biopsy. It gives patient immense satisfaction and helps in building good patient-doctor relationship. It acts as a dermatologist stethoscope and helps in pre- and post-treatment evaluation, not only of the skin cancers, but also for the inflammatory disorders. It's also very important in identifying the area truly representative for disease for biopsy sampling. And last but not least, it also has a role in aesthetics. That's all with this introductory talk. In the next lecture, I'll discuss how do these dermatoscopes work. I thank you all for patiently listening.